Thank you very much. First of all, I'd like to welcome everyone to the webcast. This is a unique opportunity, and I really look forward to presenting today. First of all, I wanted to make sure that everyone's aware that at this time I have no competing interest to report in giving this presentation, and that some medications may be discussed during this presentation or the discussion that may not be FDA approved for the conditions that are being presented today. First, we're going to talk about what's been happening here recently, and I'm going to review some of the positives in the areas of this study, and then I'm going to review some areas of definite need. So, more patients are reaching older adulthood. So right now we have about 11,000 adults every day that are becoming eligible for Medicare and entering into retirement age. And this is, of course, the baby boomers moving this large volume of people into this particular age group. We know that there are more studies being published on ADHD in older adults, and we're going to review that literature today. And we know that more patients are seeking evaluation for difficulties with thinking. Not only we have more numbers in terms of the baby boomers and sheer volume, but I think more people in general are much more sensitive to issues about their thinking and memory and are more apt to seek help than they were before. What's not happening is that there are very few studies in the United States on this topic. Most of them have been performed in Europe. There's very few studies looking at medication and the treatment of older adults with ADHD. And finally, medical education systems do a very poor job of teaching about this disorder. So, first, what's happening? We have more studies published. As I mentioned before 2008, there was really nothing in the literature about this topic. And then we had 3 published studies. One was a review that I wrote, a case study that was published about treating one patient with a stimulant and how that was successful. And then a prevalence study in Europe looking at a general health survey and showing that indeed there were a significant number of people who had ADHD who were 50 years and older. Since then, we've had several excellent epidemiology studies of the prevalence of ADHD in older adults, and all of these have been done in Europe. And several studies have also looked at the effects of ADHD on the lives of older adults. The prevalence of adult ADHD in older adults is about 3%. This is slightly lower than younger adults. It's estimated to be about 4% at this age group. One can speculate why this is, but my own guess is it actually has to do with mortality. We know that most adults with ADHD are not aware that they have ADHD, so we have a very large number of people with this disorder who are not treated. And just for one example, I think this is how this touches on the public health issue. One study speculated that if all adult males were treated for ADHD who have ADHD, we could cut the number of fatal motor vehicle accidents in half. And I would speculate that we could include other accidents. We could include things like controlling obesity. We know that there's an association between obesity and ADHD. So this is one reason that we may see a slightly lower percentage in older adults than in younger adults. And we know that ADHD definitely does negatively affect the quality of life for older adults, but perhaps less so than younger adults, or at least in different ways. The studies thus far seem to indicate that ADHD seems to have more of an emotional impact on people and a relationship impact than it does on the economic or educational issues that we more often see with younger adults. We have limited studies on the effects of medication with older adults and ADHD. Based on my clinical experience, older adults seem to respond very well to these medications, and the positive effects from the medication seems to last over time, years. And limited data suggests that these medications are safe to use in older adults. We have some literature from, for instance, treating depression with stimulants that indicates that they're relatively safe in older patients. I certainly saw no adverse effects beyond what you would normally see in a patient at any age with using a stimulant, and I thought older patients actually had much better health once their ADHD was taken care of because they were able to follow through with their medical providers and with their treatment plans. So I felt they were much healthier and much happier once their ADHD was treated. What's not happening is that these studies for medications are very few. Here are two that I'm aware of. One was a very limited publication of 11 adults, 55 and older, with ADHD who were prescribed stimulants. And the findings were just what we would expect based on our clinical experience, was what the adults seemed to do quite well with the medication. Another larger study with 149 adults was done in Norway, and this looked at their experience with stimulants. And what they found was that older patients in general tended to be diagnosed later in life, in their 40s and 50s. In general, they thought their medication was very helpful, and interestingly, they were much more likely to stay on their ADHD medication compared to studies looking at younger adults and looking at adolescents. What else is not happening in this area is that there's very few studies of ADHD in older adults in the United States. Many more studies come from Europe, especially Norway and Sweden. I'm not exactly sure why this is, but the cynic in me suspects that it has to do with economic incentives. Even though in the U.S. there's a growing market for treating all adults for ADHD, older adulthood is not seen as a distinct market, and therefore the companies who are sponsoring medication research really would be at a disincentive to study older adults with health issues compared to looking at younger, healthy adults who are less likely to have problems with their medication. At this point, except for some side notes, the DEA does not distinguish older adults from adults when approving a medication for diagnoses such as ADHD. Europe may well also recognize that ADHD is a public health problem, and by identifying it and treating it, they would have some incentive to reduce costs to the entire healthcare system by making sure that this is addressed. Finally, our medical education about ADHD and in outpatient psychiatry remains inadequate. So training on ADHD, if it exists at all, is limited in medical schools and in residency programs, and unfortunately this also includes psychiatry programs. Consequently, clinicians and researchers have a blind spot when it comes to ADHD. That may sound surprising, but it's sort of a vicious cycle. Medical school has poor training because many of the professors are unaware of this diagnosis. It's relatively new when it comes to adulthood. This follows through with residency, and then we know that ADHD is a silent disorder. It doesn't come on like the flu, or it doesn't come on like an episode of major depression. It's already on when people are born, so it's no surprise that less than 20% of adults are ever diagnosed. As medical professionals, we have to ask about this disorder, and the data is pretty clear that we're not asking about it, even when our patients may bring it up. This also includes research centers, and studies on cognitive issues such as early dementia or early cognitive impairment do not screen for ADHD. So when we look at the results from the studies, we don't know if some of the subjects they included may or may not have had ADHD. In speaking about dementia, I want to touch a little bit about any association or lack of association. Here, our data is limited, but there's both good news and possibly some bad news. The question is my forgetfulness dementia is going to be asked more and more by folks as they reach this age. Many of them will not have dementia, but we know many of them will have ADHD. So let's review what we think we know so far based on the literature. The good news is that there's no evidence to link ADHD and Alzheimer's dementia. In other words, people with ADHD do not seem to be at an increased risk for getting Alzheimer's. These are limited studies, but so far there's been no evidence to link ADHD with this disorder. If you have ADHD, you're not likely to develop Alzheimer's dementia. The bad news is that there was one small study that found a possible association between ADHD and the development of a rarer form of dementia called Lewy body dementia. Again, this was very small, only 20 patients. I mention it only because the association was quite high, and this is something that we're going to be wanting to watch very closely going forward and see if there really is an association. Important to remember, though, that Lewy body dementia is a relatively rare form of dementia, and ADHD is relatively common. The really bad news, I think, is something that we can do something about, and that is the poor understanding of ADHD in the healthcare system. I think it leads to poor care of older adults seeking evaluation of cognitive issues. So we know that studies of dementia do not screen for ADHD. We know that memory clinics very rarely will screen for ADHD when looking at someone for an evaluation, and that the clinicians most likely to first see older adults who have these concerns, such as internal medicine physicians, family practice, psychiatrists, often do not screen for ADHD. So what we have is more and more people becoming concerned about their cognition and a gap in our education system in medicine about how to screen and diagnose this. So it's really important, and one of just another small example would be the psychological testing that's often done for memory concerns. We know that if you have ADHD, your tests are going to be different than someone who does not have ADHD, and those problems with that testing may be interpreted as memory loss issues instead of being attributable to the ADHD. So that's just one example. So what do we need to do? I think what we need to do and what we can do is improve medical education about ADHD at all stages of life, and that it should be included in training programs for physicians, for nurses, nurse practitioners, physicians' assistants. Research studies on related topics like memory and aging need to consider that some of the subjects enrolled may have ADHD. And even though we're talking about ADHD in older adults, this poor understanding penetrates medical education and clinical practice from pediatrics to geriatrics. So at all levels, we need to be doing a better job. I also believe this is a public health concern. The more adults identified and treated for ADHD, in my opinion, will result in both better health for patients and lower overall costs for the healthcare system. What's needed is advocacy. First, we need advocacy from healthcare providers that we need better training on ADHD, and we need to be asking more from our medical schools, our nursing schools, PA schools, and faculty. We also need advocacy from patients with ADHD and their loved ones. So if you're thinking you might have a problem with memory, or someone you care about maybe wanting to get an assessment, it's really important that we ask if that healthcare provider understands ADHD. And if not, try and find someone who does. And support organizations such as CHAD are tremendously important in continuing the effort to advocate for educating providers and consumers about ADHD at all levels. In conclusion, what we've gone over today is that ADHD is a relative common condition found in older adults, and we know that it has negative consequences. And although studies are limited, ADHD in older adults responds well to the same treatment as younger patients, and it's safe. And we all need to advocate for better training of healthcare providers to diagnose and manage ADHD at every point in life. My own experience with treating ADHD has been one of the most rewarding in my career, and I think other healthcare providers are also missing out on this very rewarding experience. By improving awareness, everybody benefits: providers, patients, and the general community.
Thank you, Dr. Wetzel. This has been a lot of good information. Our first question comes from Elvin, and he asks, where can he find the research on ADHD in older adults?
I would definitely suggest going to a reference librarian at a local library, and if you have a medical school nearby, that would be even better. Unfortunately, there is no one consolidated journal or place. The information that I presented today comes from multiple sources, and some of it even comes from teasing out the data from even larger studies. So it is an issue. We do need a single source, I think. And as I said before, I think the time has come and is coming where we're going to start looking at ADHD in older adults as a distinct entity. But for right now, I would suggest if there's specific topics that you're interested in to go to your local library, ask to speak to the reference librarian, have a list of the questions you want to know, and they can get you some of the information. Some of these are from journals that you have to pay for online, but again, if you get them through your local library, you might be able to do that with limited cost or no cost.
Our next question from one of our participants is if there is any way to confirm that an ADHD diagnosis is accurate, especially if the person who has been diagnosed is not responding to medication.
So as I understand the question, when do we rethink a possible diagnosis of ADHD? Well, this is true in medicine of really any medical condition. A patient may come in with high blood pressure, and it seems pretty clear to us that their numbers are high and that they have high blood pressure, and we start treating them for hypertension, and it's not responding, and then we do a little further investigating and we find out maybe there was a secondary cause for their elevated blood pressure. ADHD can be very similar. There can be other psychiatric problems, such as depression or anxiety, that can interfere with concentration or focus, or it can make the ADHD worse. Medications can affect these things. If someone is abusing substances and hasn't been honest about it, that definitely can be causing problems. Sleep disturbances can be a major factor as well. I would say the most important thing is that the healthcare provider who's in charge of developing the treatment plan with the patient needs to work with the patient and the person accompanying that patient in making that decision at some point, if things aren't getting better, to relook at the diagnosis, and maybe a referral to a specialist may be in order. But any healthcare provider who's providing care for ADHD should have a good understanding of these other conditions that may also contribute to problems with focus and concentration and attention.
As a follow-up to the previous question, one of our participants would like to know how effective medications are for treating ADHD in older adults.
That's a very good question. I will tell you that from my personal experience and generally from the literature, if you look at drug studies and from what other clinicians will tell you, that in the patient who's been accurately diagnosed and treated with a level of skill that someone develops by working with adults over time, that I would say 60 to 80% of adults will notice some significant improvement, and improvement to the point where they believe that it's worthwhile to continue the treatment plan, to keep coming in for office visits, to keep getting their medication refilled. All the hassles that come with getting a prescription, 60 to 80, 70%, somewhere in there, of adults will have a good response to medication such that both they and their provider agree that they're having a good response, that it's clinically effective, and that they want to stay on their medication.
Our next question is from Leon, and he is wondering how helpful coaches and therapists are in helping older adults with ADHD.
That's an excellent question. We know from looking at all ages of ADHD that have been studied up to this point that most patients will benefit from some additional help. As a lot of my fellow ADHD providers will say, pills don't always provide skills. And I say don't always because I've had many patients, once they were able to get on medication, they were able to read for the first time. They were able to pick up a book like Driven to Distraction or other ADHD self-help books and really kind of coach themselves. But before they were able to focus and concentrate long enough to read, this was a very difficult exercise. Some patients will benefit from, say, an ADHD coach, and I think it is going to vary a lot from person to person. Depends on their personality style, depends on their interest level and their motivation. But I think knowing that you have this diagnosis is the most powerful part of the treatment. Because once you know you have it, and you're fairly confident you have it, then you and your provider can map out a treatment plan that's individualized, that works for you, and you can move forward. That treatment plan may be learning about ADHD and some ways to manage it. Some of it may include medication. Oftentimes it's a combination of medication and some additional sorts of behavioral or cognitive therapies. But knowledge is power in this particular instance. I think it's also really helpful knowing you have this diagnosis when it comes to relationships, because now we have something to work with when we're having conflict around issues with ADHD. And before, we may have called it something else. We may have called it being lazy, or we may have called it being purposely forgetful. But now we have something that we may be able to label it that actually is helpful for us. So it's not an excuse, but very often it's a very accurate explanation. So for example, if someone says that they forgot something at the store, rather than getting in an argument about forgetting something and what that implied to the other person or the relationship, we can say, well, possibly this was due to the ADHD. So next time we'll make sure and take a list. In other words, I think this really opens up problem solving in relationships when it comes to ADHD, as opposed to blaming and frustration and anger.
The next question from a couple of our participants is, what does an evaluation for ADHD look like in older adults? And does it involve a brain scan?
So a good evaluation for ADHD should begin with a comprehensive assessment. And by that I mean there should be some paper and pencil testing a little bit for screening purposes. There should be anywhere from, I would say, 45 to 50 minutes, maybe longer, of sit-down interview time. And during this time, the examiner should be asking about ADHD in terms of history and current symptoms and signs of ADHD, but there should also be a comprehensive assessment for other psychiatric disorders, because we know that ADHD and other psychiatric disorders are extremely common. In fact, some studies would indicate it's very rare to just have ADHD. it's very common to have other diagnoses such as anxiety, mild depression. Certainly substance use issues are associated with ADHD. So we can't sit down and just say, I think you have ADHD. Yes, you meet this checklist. Now let's talk about treatment. We need to rule in or rule out other possible problems that we might be dealing with in terms of anxiety, depression, and so forth. That's what I mean by the comprehensive part of the mental health evaluation. We also need a medical evaluation, which includes past medical history, current medications, any history of head injury. We need to look at family history. And this is particularly important with ADHD because increasing evidence shows that it's very genetic. And so we need to look through the family history and see if we can find other relatives that may or may not have had ADHD. This is not a requirement to get the diagnosis, but it's very, very common to find other relatives that may have been diagnosed or certainly on the surface level may have appeared to have problems consistent with ADHD. And finally, it's really important to look at where that patient is in terms of their life. Certain situations are going to bring out different feelings, different abilities to function. And so I think it's also important that when you get an assessment that the person who's talking to you has an understanding of where you came from and where you are now. What kind of person are you? Because that's going to have a bearing not only on your diagnosis, but also on how we put together a treatment plan if that's what we're wanting to go forward on. In terms of the SPECT scan, those are not considered a standard part of ADHD assessments at this time. And I think you can find some providers who would say that they're extremely helpful. But again, in terms of what you would consider sort of a standard right now, a SPECT scan is really not considered a standard when it comes to a comprehensive assessment for ADHD. Not to say that in the future, with more studies, more understanding, we may include this as part of a evaluation, but for right now, it remains sort of outside the standards when it comes to establishing a psychiatric or mental health diagnosis.
Thank you. I think that is very helpful for our participants so that they know what they should expect when going through the evaluation process. We have a few participants that are having other health problems, such as heart disease. Many physicians are reluctant to prescribe stimulant medications when there are other health problems. What do you suggest that they do or say to their doctors in order to find an appropriate treatment?
Again, an excellent question. And of course, it was one of the original questions I had in pursuing this particular topic. What does the literature have to say about this? And the answer is very little. And so it's perfectly understandable when we don't have data saying that this is safe for practitioners to say, well, if I don't have data saying it's safe, then I'm not going to take the risk that it might be dangerous, and so I'm not going to prescribe the medication. I think in this particular case, this is where we need to have a conversation with the patient about the relative known risks of these medications and the potential benefits for that patient. And the provider and the patient can kind of come together with a mutual decision. For many, many of my older patients, their decision was to give the medication a try. And as I said before, I did not see any evidence of any significant problems beyond the sort of issues that you see with anyone at any age with a stimulant. You are going to have a much more difficult time, however, finding a provider who has any idea what ADHD is or has any idea about stimulants in general. I remember the first time I considered prescribing a stimulant was for a patient with severe depression who was in the hospital. And I'd never prescribed one before. So I looked through the literature. It was very limited. And we tend to be conservative in medicine. And I think that's a good thing. However, if that conservative level of care is denying people access to something that they think might be beneficial for them, and the relative risks are understood by both parties, I'm not so sure that sometimes we may be causing more problems than we're trying to prevent. But again, most providers do not have a good understanding about this diagnosis and do not have a good understanding of the medication, so it's no surprise. And my advice is, as you might guess, to do some research and try and find a provider, not necessarily someone who's going to prescribe you medicine, but trying to find a provider who understands ADHD. They may or may not decide to prescribe medication, but I think your odds are much better of having a good, balanced conversation about the relative risks and benefits with that provider than you will with someone who may just have a passing understanding of the disorder and the treatments for it.
The next question is from Christina, and she asks, once the plan has been settled on and the prescription is prescribed, how long does it take until someone will see a difference?
As with any treatment plan, it's going to be very individualized. So the fun part, for me at least, with treating ADHD as opposed to a lot of other mental health issues that we treat is that the effects are pretty much immediate for most patients. Once we get to an adequate dose of medication, most patients can tell you, yes, I can tell a difference and I can tell when the medication wears off. And then it's a matter of titrating and adjusting the dosages so that the patient's getting the maximum amount of effect and no side effects. And the length of time that a patient is going to be in treatment is going to be an ongoing discussion with their provider, just like there's going to be an ongoing discussion about the relative risks or benefits taking the medication. There's going to be a discussion about the relative risks and benefits of stopping a medication. So those discussions may have to do with, a lot of times patients want to see how they can do off of their medicine for a period of time. And I always feel like these are the kind of discussions that are really important, because you need to feel as though you and your provider are collaborating on your treatment plan, and that the provider understands what you're saying and that you understand what the provider's saying, so that you can come to these decisions in a mutual way. And that will include whether to start medication, whether to continue the medication, and if at some point a trial off of medication. The thing about stimulants in particular, though, is that if you don't take them, they're out of your system very, very quickly, with only a few exceptions. Most of these are going to be out of your bloodstream completely by the next day. So many patients will have come in to me after not taking their medication for a weekend or a week or so, running out of their prescriptions or going on vacation, and say, I could really tell a big difference. Or sometimes saying, I think maybe I want to take some time off the medication. But the main thing is communication, that there's a good line of communication between the provider and the patient to make these decisions.
The next question is about emotional outbursts and whether or not they are a symptom of ADHD. If it is that unique to the older population? And are there other symptoms that may be unique for the older population that people should pay attention to?
I can tell you from a clinical standpoint, from what I've observed, if a person had emotional issues associated with their ADHD as a young adult, they're probably going to have them as an older adult as well. So I would be really suspicious of an older adult with ADHD who's having anger outbursts or emotionality that they didn't have before. I would be thinking about other potential causes or possibly a reaction to medication. Anytime we have something new with someone and we're in the ADHD arena, we start thinking of other things because, as I mentioned earlier, ADHD doesn't come on and at some point in your life just happen. ADHD is something that you bring with you into life. So sometimes a situation can change. For example, I had several patients come to see me when they moved from a job that was very active and physical and hands-on, and they could move from project to project, and then they were placed in a situation where they had to sit and focus for long periods of time. And they could get extremely frustrated and extremely discouraged in those situations. And that was sort of an adjustment reaction, if you will. But if it's something that's pretty extreme in terms of emotions, if it's not been seen before, I would want to be digging deeper into the history and see if there's something else going on emotionally, psychiatrically, medically, that may be triggering that if it's a new development.
The next question is from Mary. She is asking if there are any books or resources that are helpful for older adults with ADHD.
For that, I would send you to Chad. They have a great selection. And these days, we have the market to help us as well. So if you go on Amazon and you look at reviews, again, I think it's a personal thing. I saw one book that was kind of in cartoon form, which I thought was kind of interesting. So there's all different types, and I think a person should look for something that's going to be a good fit for them, that's been reviewed by other people, where they say, yeah, this seemed to work well for me. Of course, I'm going to promote my own book, but my own book isn't going to be for everybody either. It's relatively short, and I've had people say, well, I wanted more in-depth, but I kept it short for a reason. And it depends on what you want. If you want an overview of the disorder, you're going to be looking for a different book than if you want a very in-depth scientific analysis. So it tends to run the gamut. But I would go to Chad's website. I would go to Help for ADHD. I would go to Amazon, Barnes & Noble, all the online places. Look at the reviews and see if there's something that's going to be a good fit for you. And I think that's the great thing about the Internet now is we can have lots of people chime in the marketplace and say, this was a great fit for me, or this was not a great fit for me. And I think that's going to give you the best odds of finding a reference that's helpful for you.
Our next question is from Jim. He is asking if there is a limit for stimulant medications for older adults with ADHD.
Excellent question. And there's two parts to the answer. The first part is the DEA limits. And it's important to understand why those limits exist. When a drug company is submitting a drug for approval, they choose the levels that they're going to test the drug. So by and large, if you're a pharmaceutical company, you want to submit the millions of dollars it's going to take to do your study. You're going to submit levels of medication that you hope are going to help the most folks with the least amount of side effects. So trying to balance that when you submit for your review. And then if your drug is approved by the DEA, and this doesn't matter whether it's an antibiotic or a stimulant, the literature will say this is approved up to this particular dosage. Clinically, clinicians are not bound by those rules. We can prescribe dosages above or below recommended doses. And I've seen both cases. I've seen patients that do fine on very, very low doses of medication, other patients that need higher doses. And this is where the communication is so important with your provider, because some patients will need higher dosages, but your provider is going to want to have a good relationship with you because these are a controlled substance. So it's one thing to walk into a provider's office and say, I need X amount of stimulant, and I know it's 4 times as much as you normally prescribe, but that's what I need. And that may be what you need, and that's what you were getting from your prior provider. But what we need to do is have a good assessment. We need to have a good conversation about where you are with your medication, get records, etc. So because these are controlled substances very often, not all of them, but most of them are, and because of the stigma associated with them, both outside and within the medical community, and because of the nature of these medications, it's important that we have a good provider-patient relationship, and that's where the individualized treatment plan can come into place. So everybody's different, and if you think about it, just in terms of medication, some people can drink a lot of coffee and fall right asleep, and some people, 1 cup of coffee keeps them up for a day. And people vary in how they metabolize all kinds of chemicals. So that's the way we have to approach it. It has to be individualized, and someone may need just a little bit of medicine. Most people are going to need an average amount of medicine, and some people are going to need higher amounts of medication. And that's why it's so important to keep that treatment plan an active, participating relationship.
Our next question is from a woman who is asking about menopause and how that affects older adults with ADHD.
That's an interesting question, and one that we don't have a lot of data about. I can tell you clinically, lots of women will tell you that when they're approaching menopause or as they're going through menopause, they'll feel like they're not nearly as sharp. And there's a reason for that to be happening because we have fluctuating hormone levels. As the ovaries are moving into the mature stage where they're no longer producing hormones at the level they were before, hormones can definitely affect focus, concentration, and emotions. So if you have ADHD and now you're superimposing hormone fluctuations on that state, it can be rather confusing and rather frustrating. But again, this is where it's important to understand what's happening physiologically, understand that it's temporary, and that working together with the provider, working together with another provider probably who can manage hormone issues with the patient can be very helpful. So this is true not only for menopause, this is true when people have other medical conditions, and I think it's true also with normal aging. I saw this in a number of patients where their ADHD was much more manageable in their 40s, but with normal aging, they seem to be having more difficulty, and sometimes their treatment plans needed to be adjusted accordingly. So it's interesting. We see it clinically. We do need to get some more studies on the effects of aging with ADHD in older adults.
And this is our final question. Several of our participants are asking how you can find a healthcare provider who specializes in older adults with ADHD.
Unfortunately, it's a kind of a small group. This gets back to my concern about training and education. The better job that we do training general medical providers and general psychiatry providers, the more people we're going to have who understand the diagnosis. And I tell people I specialize in adult ADHD, but really that's not an accurate statement. What's more accurate is that I include ADHD as being a psychiatrist, and I think all psychiatrists should. I don't think this is particularly difficult to learn. I think once you learn it, it's relatively easy to incorporate into a general practice. That being said, For a lot of patients, CHAD has providers who are registered providers, and so you can go to their website. I think a big help is local medical centers. So if your state has a medical school, calling them and asking, particularly in the Department of Psychiatry, if they're aware of any providers in the region who may specialize in this particular area, or calling a larger psychiatry group, for instance, where there's a number of providers, and asking if they have a specialist there or if they know of anyone else in the community. It's oftentimes by word of mouth that you're going to find the best reference.
This concludes our Ask the Expert webinar. Thank you, Dr. Wetzel, for providing us with your expertise.